So tell us a little bit about what you're going to be presenting at PaRADigm.
We have thought about challenging the traditional role of pathologist and radiologist in an academic institution. We have been for too long two silos that don't really talk to each other. And yet with the evolution of AI and patient care in the virtual realms, we see those silos need to be broken down, and we really are advancing the concept of a diagnostic medicine, which incorporates radiology and pathology together. So Chris here is my buddy, and the radiology chair and the pathology chair at UTMB are attached at the hip to make this happen.
That's great. Tell me a little bit about at UTMB, how are you making this happen? And I know you all just received a large grant to help kind of foster this idea, this concept of diagnostic medicine.
Yeah, Chris.
Yeah. So we did. For the next 3 years, we're going to be funded to create what we refer to as diagnostic management teams. These are multidisciplinary teams that are focused on the diagnosis of the patient. It probably sounds a little bit reductive, and maybe everybody here would agree with this philosophy, but we think that the highest leverage moment in a patient's care pathway is the moment of diagnosis, as opposed to the moment of therapy.
Oh, that's interesting.
Yeah, I mean, because everything follows from that initial domino, right? I mean, if you don't get that domino right, then you go the wrong way, and things don't seem to happen quite right for the patient.
Including the billing side, right? I mean, you know,
that's exactly right. Absolutely. Everything, the complexity of the billing, everything. And so from an administrative standpoint, if we get that moment right, then we'll bill the patient properly, and we will get them out of the hospital much faster. And so for us, this initiative from the Seeley Smith Foundation for the Diagnostic Center, we're going to really focus on improving those diagnostic turnaround time metrics that we're going to develop and then hone through the next 3 years. So that's our real initiative, is to try to understand administratively what's the most effective for patient care, and then deliver that.
That's interesting. And I know my participation with this, with Bob Tessier from the pathology side, is kind of like, well, how would you bill for this, and who, you know, splits what? What's interesting to me is that you've been able to come together and not worry about that part of it first, right?
Yeah, we don't want to, we really don't make the financial aspect of it the driver. As with everything, it's going to be part of the equation, and we're going to have to think about that. But there are mechanisms through CMS and through some of the commercial payers that they will compensate you for things like interprofessional consultations and other mechanisms that pathology and radiology do quite well, that will actually bring some money to the table to support our efforts.
Yeah, and on that note, one of the things that we have had within the Department of Pathology that is now sort of being extended in this integrative approach is we've had these DMTs that are limited to pathology, areas where radiology isn't necessarily as involved. And so in that effort, we've done a number of, 2 or 3 small studies where we've shown the value at the health system level. So for example, we've done a DMT for COVID diagnostics that generated, tens of millions of dollars in additional revenue, and it was, spearheaded by 3 people. And so that's $20 million that's real dollars. That's not like fake money that we say, oh, we saved this. No, that was billables that we were able to generate because of this effort. And in addition, the hypothetical component was healthcare delivery was improved. We found that we compared ourselves to academic medical centers that were similar to ours, and we've saved, tens of, maybe even hundreds of people in this community because of that effort. So we have the quality care improvement as well as the additional revenue. And so we think that we take that model and we now expand it to include radiology, and the two of us will address almost every area of the hospital. I mean, radiology touches a lot of areas that pathology really has no business touching. And that will make, those two will be extremely powerful.
Yeah, that's very interesting. I mean, better outcomes, right? Bringing value to the bottom line. You see this ultimately, and I know our diagnostic medicine focus group has talked about this, is starting kind of an academic setting, but moving out into community medicine. Do you see that happening over time?
Yeah, I think you will. We see that this is a very fluid patient population now, the young people, and
Uh-huh.
they have a problem, joint pain, hurt their neck skiing. They can come to an outpatient imaging center, whatever you want to call it, a diagnostic center,
Mhm.
and we can have nurse practitioners, we can have our nurses see that patient, we can get the imaging, we can get the labs, and we can give them a diagnostic report, and then they can go see their specialist rather
Mhm.
than the other way around.
Okay,
So
yeah,
we
right,
think we short circuit a lot of the diagnostic work because we put it right up front,
right,
in
right,
front of the patient. So there's obviously some problems with that. You're going to encounter some resistance, but
right.
we have, with the Seeley Smith Foundation, we have people that are really interested in looking at this cutting edge technology and funding it. And that's what's really important,
Yeah, it's interesting on the policy side. There are some states where there's been some bills introduced just this year that would preclude a health system or a healthcare provider from providing a report earlier than 48 hours after a test. So it kind of counters what we're talking about. And I'm wondering how this research may help uh, delay that kind of thought. It's kind of interesting. It's backwards.
That's a great question. I mean, all of us have an EMR where the patient sees the biopsy report the same time we do.
Right.
And
Yeah,
that's
right.
some issues, right? It's
Yeah,
created some issues, but that's what the public demands. And, I
yeah.
don't care what the commercial payers or CMS says, the patients are going to get what they want. And we want to be in the forefront of that.
Yeah.
Well, and I presume this is perhaps a very good application for some type of artificial intelligence at some point, right? I mean, you're working with that too, Chris?
Yeah, part of our collaboration between Chris and I and our departments is to create a layer between us, which is primarily artificial intelligence. How do we use AI to make the diagnostic yield better and
Uh-huh.
faster? And we also roll a lot of our funding into that because we don't really want to buy our AI. We want to use our own data to create our own
Right.
to fuel the diagnostic center. So yeah, that's a very important component. And it goes right between us. We
Yeah.
both manage.
That's right.